Okay, good morning everyone. I'm Dr. Isha Acharya. I'm going to present on the paper Variation of Visual Acuity and OCT Biomarkers with Choroidal Thickness in DME. So, ischemia and vascular hyperpermeability due to protein leakage in the choroidal interstitium has been reported in cases of DME, but there has been conflicting evidence regarding the central choroidal thickness in DME. Some authors say it is either thickened or thinned, or there is no change at all. And to the best of our knowledge, there has been no study in the literature to analyze the association of central choroidal thickness with visual acuity and other OCT biomarkers in DME, hence the present study. So it was a retrospective observational study which was divided into two groups with a CCT less than 300 microns and CCT more than 300 microns. So inclusion criteria was all patients with center involving DME, and subfoveal CCT was measured using the EDI mode of the Heidelberg Spectralis machine, and no eyes were treatment naive. And CFT was also calculated. Cases of VMT and OCT without any EDI scans, myopia of more than -6 diopters, and other systemic conditions like hypertension and kidney disease were excluded. So these were the OCT biomarkers which were studied: hard exudates, hyperreflective dots, hyperreflective choroidal foci, intracystic choroidal hyperreflective material, and drill, and the EZ and ELM disruptions. So 100 eyes of 83 patients were studied, and group 1 had 54 eyes and group 2 had 46 eyes. Overall mean follow-up was around 13 months, and male preponderance was seen in both the groups. The mean age in group 1 was around 65 years, and in group 2 it was 62, while again male predominance. So on presentation, the poor visual acuity that was seen more in with group 2, but it was not significant. And in PDR, eyes were more commonly seen in group 1, again non-significant. Mean CCT was around 227 in group 1, while in group 2 it was 340, and mean CFT was 448 and 462 in group 1 and 2 respectively. So OCT DME pattern and biomarkers on presentation showed this figure that SRF was significantly more commonly seen in thicker CCT group, and the SHRM, the intracystic hyperreflective material, and HCF as well as drill was seen more commonly with group 2. All patients received a minimum of 3 intravitreal injections during the assessment period, with intravitreal anti-VEGF being most commonly used. Additional treatment like focal or grid laser was also used. So this was the progression in which we saw that the EZ-ELM disruption was anytime more commonly seen in the final follow-up in group 1 as well as group 2. Also, the HCF was marginally more in the final visit. So mean CCT and mean CFT on final visit showed something like this, and CCT was significantly decreased in group 2 than group 1 on the final visit. Visual acuity was seen, visual acuity gain was seen in 20% and 23% in group 1 and 2 respectively, again not significant. So this was the DME pattern and biomarkers on the final visit after treatment. So again, the SRF had significantly reduced, but it was in group 1 and group 2 it was non-significant, and HCF was still increased in the final visit. So as compared to the other studies, Amjad et al. Said that there was increasing severity of retinal edema was associated with more choroidal thickness. However, we in our group also, thicker CCT showed higher frequency of patients with CME on presentation, but it was statistically non-significant. Also, they found that there was no significant difference with or without SRF regarding choroidal thickness. However, in our study, we found that SRF was significantly more in the thicker CCT group. CT significantly decreased in PDR and DME eyes, as told by Adi M. et al. In our case also, the frequency of PDR was seen more in group 1 than group 2. And greater choroidal thickness was suggestive of intact choriocapillaries, hence lesser EZ damage. In our case, group 2 had marginally lesser EZ-ELM disruption, but it was totally non-significant. So these were some of the theories given for thicker CCTs and thinner CCTs. For thicker CCTs, it is either more VEGF protein and other inflammatory products in diabetes. And in thinner CCTs, it is most commonly related to a retinal tissue hypoxia, and also the anti-VEGF and laser treatment that these patients receive. So thicker CCTs was associated with relatively increased biomarkers both on presentation and final visit. SRF was seen more often in patients with thicker choroid. Patients with thicker CCT presented relatively more with poor visual acuity. CCT did not significantly affect any OCT biomarker as well as visual acuity. And CCT along with OCT biomarkers may provide an insight to overall prognosis in DME. Thank you, everyone.
Were they treated patients or all?
They were treated patients, but we have taken in a particular time period how it changes.
Will it affect your study?
Yes, sir.
Will it affect the result?
But it's like more or less more than 3 intravitreal injections we have taken a minimum who have taken. So it should affect, as I've already said, that anti-VEGF and laser treatments may affect the CCT. But in our study, there were no treatment naive patients. So more or less the parameters should have been the same for these patients.
So the measurement was done after exactly fixed dates or fixed interval after the anti-VEGF?
More or less in a 1 year time period.
That's very interesting data. I think even PHCR does tend to show significant change in the choroidal thickness, probably especially where the lesion is present, and this is really upcoming, this thing which I think needs to be studied. I think DME, obviously, I think one thing that I don't agree with is laser, because that would definitely change things, and it should not be a part of the study ideally. And ideally we should have single probably have treatment naive patients to be studied in these cases, because, and obviously change in choroidal thickness or later on change in the visual acuity per se would be a different this thing. But just to standardize the algorithm, I think primary treatment naive patients would have been a better this thing to and also standardize the disease. I think that probably in your next this thing you could probably pick up one disease entity or one biomarker and then study it and then see whether it's statistically significant or not. Yeah, thank you.
Just one question. You wrote that CCT don't have any relation with the other biomarkers, correct?
Basically, SRF, as we studied, like SRF was more commonly seen.
But the drill and other things,
others more or less like hyperreflective choroidal foci had been always more in group 2.
So that is
hyperreflective choroidal foci is a marker of inflammation.
I'm asking if CCT we are thinking then predicting that it is it's just suggesting if in a future study. So if we predict that okay CCT is responsible, means we can predict the visual acuity of diabetic patient depending on the CCT. So but if we don't see the interaction between the CCT and those biomarkers, those will be the confounding factors. So you cannot come to a conclusion like that. So either you take the patients with the biomarkers more or less same level and then exclude them so that that factor is omitted, and then you do the CCT and you can tell that okay these biomarkers are okay but CCT is just different, so this must be the factor which is having effect on the vision, correct?
Okay.
Thank you.
Yes.
Okay. Yeah. Thank you. Please sign here. Yeah. Please sign this. Okay. So we'll conclude the session here. Thanks a lot everyone for attending.